Okay, we are very fortunate to have yet again Elias Klemperer to come and tell us what's going on up in Vermont in the with respect to opioid use disorder and correctional settings. And you know, this we've heard him talk on this topic before, but this is really exciting to get an update. And I think I was just on a meeting recently and they said, oh, well, there's only 2 states that are doing it, as you know, Vermont and Rhode Island. And so I think, you know, Vermont had a jump on the rest of us in terms of taking the opioid epidemic seriously. The governor leading the charge and devoting his entire State of the State address to it, and started out with this, you know, building this wonderful hub and spoke model. And they had everything but corrections there, and it was a perfect setup to just add in corrections. So they did that maybe 4 years ago, 5 years ago, and or maybe less, through legislative action. And now we get to see the results. So take it away.
Thanks, Jody. Let me see if I can share my screen here. And I think everyone see my, oh, I think I have the wrong slide up here, sorry.
So right now, I cannot see your screen. This is Gail.
Thanks, Gail. Just give me 1 second here. How about now?
Perfect.
All right. We even practiced this beforehand, so should get it. Well, thanks so much for having me come talk today. My name's Elias Klemperer, and I'm from the University of Vermont, and I'm project director in our Cobry Center at UVM. So it's a real treat to get to come talk to you today on the findings from this evaluation. Specifically, I'll be talking to you about a statewide evaluation of the implementation of medications for opioid use disorder in Vermont correctional facilities and the impact of COVID-19. Most of my research at UVM is in tobacco. My clinical work, my background's in clinical psychology, and my clinical work has been largely focused on treating addiction among people who are incarcerated or recently released from incarceration. And so it's been great to get to merge the two with this evaluation. So to start with, here's my disclosure and funding information. This evaluation was funded by an NIH Yale initiative through the Justice Community Opioid Innovation Network, or JCOIN. So really grateful to have that support in addition to Cobry support. So I'll start with an outline of what I'll talk about today. First, I'll give you a little bit of background information about opioid use disorder in Vermont, the act that implemented MOUD, or Medication for Opioid Use Disorder, within correctional facilities. That's Act 176. And I'll talk to you a little about our Department of Corrections. And then I'll get into the methods of the evaluation, specifically talking about the sources of the administrative data we used and our aims and analyses. And then I'd like to spend the bulk of our time today talking about findings from this evaluation. So I'll try to present a lot of data as succinctly as possible, specifically focusing on treatment while incarcerated and how that's changed over time, treatment after release from incarceration, as well as fatal and non-fatal overdose. Then I'd like to save some time for questions so we can have some conversation at the end. So as most of you are well aware, the opioid epidemic in the United States has had devastating effects, especially when it comes to overdose and fatal overdoses. And in Vermont, we unfortunately are no exception to this. In 2018, we had the 11th most opioid-involved deaths per capita at about 23 per 100,000. This epidemic is continuing in Vermont. In particular, we're seeing these numbers increase. You can see here, this appears to be driven largely by fentanyl in our state. And 2021 data unfortunately look like we're continuing to see these overdoses in the context of the ongoing COVID-19 pandemic. So the focus of today is on the intersection of opioid use among people who are incarcerated or recently released from incarceration. And it's important to note here that as part of the war on drugs and mass incarceration in the United States, we have a system where over half of incarcerated individuals, according to the Bureau of Justice, meet criteria for substance use disorder. And while they don't report specific diagnoses for opioid use disorder, we have good reason, national data suggests that OUD, the prevalence of OUD is really overrepresented in correctional facilities. So we have a really high concentration of people, either current or history of opioid use disorder in our correctional facilities. And this is a problem for a number of reasons, but when it comes to overdose, what we know is overdose is a leading cause of death after release from incarceration. And specifically, this period right after release from incarceration is an incredibly vulnerable time for folks with a history of opioid use disorder. Estimates range widely, but confidently we can say over 10 times more likely to overdose within the first 2 weeks of release from incarceration compared to age-matched controls. So this is a population with a high prevalence of opioid use disorder and a really elevated risk of overdose after release from incarceration. Now, when it comes to treatment, fortunately, we have medication that can help. And so the only empirically supported treatment for opioid use disorder is medication for opioid use disorder, or MOUD. Previously, we referred to this as MAT, medication-assisted therapies. These include buprenorphine and methadone. So these are opioid agonist therapies, as well as naltrexone, which is an antagonist therapy. That means it blocks the effects of opioids. A number of meta-analyses have demonstrated that counseling, in addition to MOUD, doesn't add much additional benefit here. So we're really focusing on MOUD as the primary treatment in this population. Now, unfortunately, most people incarcerated in the United States, as you heard Jody mention in the introduction, do not have access to these medications, do not have access to MOUD. So this leads to forced withdrawal, which is traumatic and could serve as a barrier to future engagement in MOUD and heightens the risk of overdose after release from incarceration. So as Jody mentioned, the first state to do this, to implement MOUD for folks who are incarcerated, was Rhode Island. Tracy and Jody both led that and wrote up some findings there. And Vermont followed suit afterward with Act 176. And so this is the act that introduced MOUD to all correctional facilities in the state of Vermont and required them to offer all 3 FDA-approved medications. It instructs the state of Vermont to provide MOUD as soon as possible and as long as medically necessary, and specifically directs the healthcare provider in the correctional facilities to administer buprenorphine as the frontline treatment and then offer methadone and naltrexone as medically necessary. So a little less than 4 years ago, but well, maybe coming on, close to that now. In 2018, this bill was passed. Implementation began in July of 2018. And then the act, sorry, I said a bill, this was Act 176, required a report for the Vermont legislature in a couple of weeks here. And so the J-Coin funding is what allowed us to do this report as evaluators. And we are submitting this in a couple of days for the Vermont legislature. So briefly want to talk to you about correctional facilities in our state. We are one of 6 states that have a unified state-run jail and prison system. So what that means is both prisons and jails are housed under the same roof. We have 6 facilities, 5 are male, 1 are female. The majority are white, with about 10% of incarcerated individuals who identify as Black. And the treatment, the structure that we have in our state is the hub and spoke model. And so this is something that was pioneered in Vermont and has since been disseminated to other states. This is important to note when we're thinking about continuation of care for folks who are incarcerated with an opioid use disorder and then released back in the community. So the hub and spoke model has, in our state, 9 regional hubs. These hubs are intended to offer treatment for more complex addiction. They provide assessment and all 3 medications for opioid use disorder, as well as counseling. And then importantly, they provide training and consultation for the spokes throughout the state. So you can see the hubs there on the map to the right. In addition to those, we have over 75 spokes in communities throughout the state of Vermont. And this is really intended for ongoing treatment within community settings. Most of these providers are in primary care or family medicine buildings to maintain individuals on their medication. And if they're involved in counseling, that as well in the community. So that's a little setting for you, a backdrop to this evaluation. But in addition to Act 176, which implemented medication for opioid use disorder in correctional facilities, we had another major event in our state as well as the rest of the world, which is the onset of COVID-19, the ongoing pandemic here. This affected virtually everything, and in correctional facilities in Vermont, operational procedures in response to COVID began in March 2020. They involved a whole range of evolving practices, but the standard medical screenings, increased social distancing, regular testing, protective personal equipment, as well as a rapid decline in the incarcerated population in the beginning of the pandemic. This was not an official stated policy, but you can see here from the graph, it starts in March of 2020. You can see here from the graph that the incarcerated population decreased pretty dramatically after the onset of the pandemic. And anecdotally, we've been told that nonviolent offenders were released more readily, and incarcerated new offenses were incarcerated less. So all this to say that these changes likely had some impact on the treatment of opioid use disorder for people who are incarcerated. So this evaluation sought to look at data pre versus post these 2 major events. First being Act 176 in July, the second being July 2018, and the second being the onset of the COVID-19 pandemic in March of 2020. And so we're left with 3 time periods. Period A being the time period before medication for opioid use disorder was available and before COVID-19. Period B after MOUD was implemented in correctional facilities, but before COVID-19, and then period C after MOUD was available and during the ongoing pandemic. So this led to our aims for the current evaluation. And specifically, all 3 are aimed to assess before versus after these time periods. But aim 1, we want to focus on change in medication for opioid use disorder utilization and characteristics of treatment engagement while people are incarcerated. So looking at VOC data. Aim 2 is looking at treatment engagement following release from incarceration, which again is important given that elevated risk for overdose immediately after release from incarceration. And then aim 3 is focusing specifically on fatal and non-fatal overdoses after release from incarceration. Now, in addition to this, we have 2 qualitative studies that will be starting in the new year. Just received IRB approval, which I'm very excited about. And the first qualitative study will interview a series of healthcare providers and administrative leaders in the correctional facilities in each facility. The second will interview 28 people who are incarcerated and receiving medication for opioid use disorder to get firsthand accounts of what these experiences are like and identify potential barriers to treatment while people are incarcerated. I won't be talking about that today. We'll be focusing on aims 1 through 3. So for aims 1 through 3, the data sources, these are all done with administrative data. Data sources here are displayed on the screen. For aim 1, looking at treatment utilization while incarcerated, we received that from the Department of Corrections and then linked these data to Medicaid claims data for aims 2 and 3 provided by Vermont Blueprint for Health and the Vermont Department of Health. There are a couple of important limitations I want to talk to you about these administrative data. First is the Department of Corrections was not able to provide data on their opioid use disorder diagnoses during the evaluation time period. So what that means is we were unable to assess changes in their assessment procedures and how that, or the changes in the prevalence of opioid use disorder per their assessments throughout this time period. We do, however, have Medicaid claim diagnoses for opioid use disorder that we use to identify individuals who had a diagnosis of opioid use disorder. We also rely on Medicaid claims data for evaluation after release from incarceration. In Vermont, about 80% of people released from incarceration have Medicaid, but again, this is a subset of the total population after release from incarceration. So we use multi-level modeling to account for both individual in the analyses and number of releases and compare these three time periods. So just to give you a quick orientation to the results, I will do my best to keep period A in blue, period B in red, period C in green, to try to differentiate between these three time periods. And then I'll cue you into where the data came from in the upper left corner of the screen using the logo from the agency that provided the data. So AIM-1, again, provided by DOC, the data provided by DOC. And this is looking specifically at MOUD and utilization and characteristics of treatment while incarcerated. So to start with, here is a very busy table just displaying the demographic information from the incarcerated populations in these three separate time periods. Briefly, what we want to note here is that most people incarcerated in our state were in their mid-30s, male, white, non-Hispanic, and single. But I do want to draw your attention to the change in what will be our denominator here, the total incarcerated population throughout our time periods. You can see between 5,000 and 6,000 individuals before the onset of COVID-19, periods A and B. But then as we saw in that figure, this population decreased pretty dramatically to around 3,000 individuals after the onset of COVID-19. So to start with, I'll present some data on MOUD prescriptions among incarcerated individuals. So this is numerator, any prescription for MOUD, a denominator is the total incarcerated population in our state. And this is when the proportion that received a prescription while incarcerated. So you can see pre-Act 176, before MOUD implementation, almost no one was receiving medication for opioid use disorder while incarcerated. After the implementation, we see that increase dramatically to about 34% of the incarcerated population who received a prescription for MOUD. And then with the onset of COVID-19, that proportion decreased significantly to approximately 27% of the incarcerated population. Now, taking a closer look at the type of medication that was prescribed among individuals who received an MOUD. So here our denominator is anyone who received an MOUD prescription while incarcerated. Numerator is looking at the what type of medication they were prescribed. First, I want to draw your attention to this small sample size here in period A. This is reflecting the fact that almost no one was prescribed a medication prior to Act 176. And so we'll really want to focus on periods B and C here after MOUD was available while incarcerated. True to the Act, most people were prescribed buprenorphine, with approximately 14% in each time period provided with methadone, and then very few received naltrexone. And the proportion provided buprenorphine did not change significantly with the onset of COVID-19. Now looking a little closer at those who initiated versus continued medication for opioid use disorder upon incarceration. And here, when we talk about initiation, these are folks who are not receiving medication for opioid use disorder in the community, but then started that as soon as they were, or when they were incarcerated. Whereas those who continued were receiving the medication in the community, continued their medication while incarcerated. Again, small sample size in period A, so we'll want to focus on periods B and C here. And what you can see is about 63% of people who received an MOUD while incarcerated initiated that medication upon incarceration in period B, and that decreased significantly to approximately 54% in period C. Now, this is important because these are folks who were not receiving MOUD in the community, but then identified by the DOC healthcare provider as someone who needed these medications, someone who had an opioid use disorder, and then received that medication, initiated that medication while incarcerated. So this is potentially connecting someone with treatment that needed treatment but was not receiving it in the community. So next I want to talk about discontinuation. So here we took a look at what proportion of the population received a medication while they were incarcerated and then discontinued that medication for opioid use disorder prior to their release from incarceration. So the denominator here again is anyone who received an MOUD prescription while incarcerated. Numerator is those who discontinued before release. Again, very small n, and no one was discontinued prior to Act 176. But in periods B and C, we see that about 16% were discontinued or chose to discontinue their medication for opioid use disorder prior to release in period B. That number decreased significantly with the onset of COVID-19 by about half to 8% in period C. Now, it's important to note here that individuals could have discontinued more than once. So certain individuals started medication, discontinued, restarted medication, discontinued again. And in fact, we have about 54 people in period B and about 20 people in period C who discontinued more than one time. So what this leads to when we're looking at reasons for discontinuation is numbers that add up to greater than 100%. But here I'll present to you data on what was entered into the system by the DOC healthcare providers as the rationale for discontinuing the medication for opioid use disorder. So important to note, this is any MOUD that was discontinued. The red bars represent discontinuations that occurred in period B. The green bars represent discontinuations occurred in period C. And in most, let me say one more thing before I get on to describing the data. These reasons were entered by DOC healthcare providers and could be either entered in a drop-down menu that had pre-specified reasons, or could be entered qualitatively. They could just write in their own responses, and reasons were not required by the system. And so we went in and with a few raters, collapse these into the categories that you see here on the screen. But we did end up with approximately 26% missing data in period B. And so for that reason, we didn't compare reasons for discontinuation between time periods, because if that missing data had all fallen in one of those categories or distributed in certain ways, the story would be told, would tell a much different story. So we thought it best just to present the raw data without conducting analyses. What you can see is the most common reason for discontinuation was diversion, or reported stockpiling or concealing the medication for transfer to another person who was incarcerated. After that came patient request, and then very few were discontinued due to non-compliance or for medical reasons. In terms of diversion, the stated policy in the Vermont Department of Corrections is a quote, 3 strikes and you're out. So what that looks like is if someone is identified as attempting or succeeding in diverting their medication for opioid use disorder 3 times, the 3rd time they're discontinued from that medication. So I want to move on to aim 2, and this is now looking at outcomes after release from incarceration. So treatment engagement in the community after individuals are released. And these data are from Medicaid, provided by Vermont Blueprint for Health. I'll be presenting number of releases as the unit of analysis here, because many individuals were released more than one time during our time periods. So what that looks like in period A, we had a mean of 1.6 releases per individual. Period B, a mean of 1.8 releases. Period C, a mean of 1.3 releases per individual. So again, the unit of analysis here is release. First question, and I think this might be the most meaningful result of the entire evaluation here. This is MOUD utilization within 30 days after release from incarceration among people with an OUD diagnosis. These are folks who have an OUD diagnosis in their Medicaid chart. What proportion of them followed up and received MOUD in the community within 30 days after release? Again, that's a very vulnerable time with high risk of overdose. And what we see is approximately 34% of releases prior to Act 176, before MOUD was available in our correctional facilities. 34% resulted in MOUD in the community. That proportion increased to 41% of releases that resulted in an MOUD prescription after release from incarceration. And that increase coincided with the implementation of MOUD in correctional facilities, so from period A to B. But then that did decrease slightly and significantly down to 36% of releases that resulted in an MOUD prescription in the community after release from incarceration. And so next I want to drill down a little bit here. And in the prior slide, the denominator was everyone who had an opioid use disorder diagnosis. Here we'll look at MOUD prescriptions after release from incarceration among those who received an MOUD prescription in the correctional facility. So a different way to say that is, what percent of people who were prescribed MOUD by the correctional facilities went on to continue that MOUD in the community within 30 days after their release? And so this is limited to periods B and C, given that prescriptions were almost none prior to Act 176. And what you can see here is a little less than half, about 48% of people who received an MOUD, or releases that had an MOUD prescription while incarcerated, resulted in continuation of that in the community within 30 days. Then that decreased numerically, but not significantly, down to 41% with the onset of COVID-19. So moving away from medication, now I want to take a closer look at counseling in the community after release from incarceration. The denominator here is all those who had an OUD diagnosis. And again, looking at releases. The first cluster of bars on the left, again, period A is in blue, period B is in red, period C is in green. We see consistent decline in the proportion of releases that resulted in SUD counseling within 30 days of release. This is counseling specific to addictions, and we see that number decreasing both with Act 176 as well as the onset of COVID-19. Looking at the cluster on the right here, we see a similar pattern, although changes between period A and B are not significant, demonstrating that really only we start to see reduction in mental health counseling with the onset of COVID-19. So next, I want to present to you data on emergency room utilization, or emergency room visits within 30 days after release from incarceration. Before I present this, it's worth noting, as with all the data I'm presenting today, these are correlational. And so changes, it's unclear if changes are related to change in need for, say, the emergency room, or change in access, or change in ability to get to different forms of treatment. So in terms of ER access, we see that this hovered around 13 to 15%, both pre and post Act 176, periods A and B. Didn't change much, but we do see a small but significant decline in emergency room utilization with the onset of COVID-19. It's important to note here that this is all-cause ER visits, so any reason to go to the ER, and not necessarily limited to going to the emergency room due to an opioid overdose. However, the next set of data I'll present, or the next set of findings I'll present, are specific to opioids. So here we're looking at fatal and non-fatal opioid-related overdoses during the year after release from incarceration. These data are from Vermont Department of Health, as well as the Vermont Blueprint for Health. And denominator here is all of those who had an opioid use disorder prior to their release from incarceration. So to start with, I want to draw your attention to the vertical axis here. You can see we have a really small prevalence of overdoses. So this is zoomed in here. And because of that, we did not run analyses on these data, but just present them descriptively here. You can see a pattern where with the implementation of MOUD, this first cluster of bars, from period A to period B, we see numerical decrease in the proportion of releases that resulted in a non-fatal overdose within 30 days after release. And then more than doubling the percent of releases that resulted in a non-fatal overdoses with the onset of COVID-19. So that's represented in period C there. Now looking at the next cluster over here, specifically looking at fatal overdose related to opioid use within 1 year after release. We expanded this out to 1 year, given the very small number of overdoses to have meaningful data. We see a reduction from approximately 1.1% of releases that resulted in fatal overdose to almost none. So that exact number is censored due to the small number to protect confidentiality, but it's almost no overdoses, fatal overdoses within the year following release from incarceration in period B. We don't have data from period C yet. 2021 data were not available, but preliminary reports indicate that we'll see a similar pattern that we see in non-fatal overdose with a spike in fatal overdoses during the ongoing COVID-19 pandemic. So I'll say that this is consistent with Rhode Island findings from this group here that found approximately 60% reduction in fatal overdoses with the onset or with the implementation of MOUD. So it's nice to see that. So I just presented quite a bit of data, quite a bit of findings here. So I'd like to zoom out and provide a broad summary and hopefully some conclusions, and then save some time for questions after that. So first, evaluating pre versus post Act 176. So these were represented by periods A and B in the slides. We saw pretty consistently an increase in MOUD utilization, which is indicating that the DOC did its job and implemented these medications in correctional facilities, and this had an effect on the continuation of that medication in the community. We also saw a decrease in substance use disorder counseling after release from incarceration, which could represent a shift in the community, people being released and turning to MOUD rather than just counseling for opioid use disorder. We also saw numerical decreases in non-fatal and fatal overdoses, which is good news and further provides evidence for the benefit of implementing MOUD in correctional facilities. The story is slightly different when it comes to COVID-19. Actually, I should say we're seeing opposite trends when it comes to COVID-19, which is a decrease in MOUD utilization, both while incarcerated and after release from incarceration. These could be due to changes in population characteristics. As I mentioned a couple of times, we saw this pretty rapid decline in incarcerated population. So those who remained incarcerated may look different and could have different treatment needs or access to treatment than those who were released. Alternatively, and what's supported by a number of other studies, is that we're seeing increases in barriers to care with the current pandemic. So things like restrictions on in-person contact, safety restrictions are also reducing individuals' ability to get access to some of these treatments. Along with that, we saw reductions in both substance use disorder and mental health counseling, again, likely due to these increased restrictions on in-person contact and other factors that could reduce access to counseling. Finally, we saw a reduction in emergency room visits and a numerical increase in non-fatal overdoses with the onset of COVID-19. And these are supported by prior studies that demonstrate both reductions in ER visits and increases in overdose among people with opioid use disorder during the ongoing COVID-19 pandemic. There are a number of important limitations and strengths here. I'll just touch on a few briefly. First, I want to point out, I said this before, but I think just very important to be reminded, these are observational data, so correlational findings here. We really need experimental longitudinal prospective studies to take a closer look at some of the findings that I talked about today. And there are a number of limits to the administrative data. First is that we don't have OUD diagnoses from the Department of Corrections. And so it'll be important to see how their sensitivity to diagnosing opioid use disorder has changed over time and how that plays into diagnoses as well. Then finally, I presented data on MOUD prescriptions in the community. We don't have data on actual adherence to those prescriptions. So again, in our state, it would be nice to have a follow-up study to look more closely at that. A couple of important strengths, we had statewide data and linked between multiple agencies. It is really impressive to get to work with folks from these agencies, and an evaluation like this requires a whole lot of work to connect these data sources. So I think that was a real strength of the study. A couple of important next steps. We, as I mentioned before, have 2 qualitative studies coming up where we hope to drill down on these issues here. The first is understanding more about what incarcerated individuals' experience is with MOUD during the ongoing pandemic. And the second is to learn more from people who are doing the prescribing in the Department of Corrections, to learn about their practices of prescribing, as well as, and importantly, their discontinuation practices. And then finally, we have data that we're going through now looking at changes in disciplinary reports, changes in illicit drug use while people are incarcerated, and then also changes in recidivism during the current evaluation period. And then all of this, I think, will lead to some important next steps regarding identifying ways to improve continuation of care for individuals with opioid use disorder who re-enter communities in Vermont during the ongoing pandemic. So I will stop there, save some time for questions. But before we do that, I just want to thank the fantastic collaborators on this project, UVM, Steve Higgins, Rick Ross, and Andrea and Abby. And then really working with the folks in the DOC has been just exceptional to get to collaborate on a project like this, as well as Vermont Blueprint for Health. And then Liz Evans is the director of UMass Chacoin, who has been helping out with this project and just been a fantastic help with this. So thanks.
Wow, that was fantastic. I think first we should try and see if there's anyone in the audience that has questions. And I guess, Gail, I don't know if you can identify individuals or how they should do that.
I can. I know that Dr. Green has a couple questions, and I see one from Michelle. So Tracy, if you want to.
Hello, thank you so much for this fantastic presentation. It was great. I actually have like a dozen questions for you, but I will hone it down to a few. But it was wonderful. And I was wondering if you could describe us a little bit about kind of post-release housing and what housing supports are in existence for people in Vermont who are leaving incarceration to support their MOUD transition and success. And then I was also wondering, I was curious about the kind of combination of methadone or the distribution of methadone and buprenorphine. It seems like it was very heavily buprenorphine distribution and uptake. And just wondering if there are any efforts to expand methadone increases, and especially with just expanded access to methadone during the COVID crisis and stuff as a strategy.
Both really important points. And the first, I'm afraid I don't have a whole lot of information I can share. I don't know all the details on the services available to people released in the state of Vermont to connect them to housing, but That's crucial, especially when considering stability and ability to get into clinics to receive MOUD. I do know that people are assigned a caseworker, and there is a team to help people make that transition, but I don't, beyond that, have a lot of detail on what is provided for those folks. In terms of buprenorphine, Vermont tends to be, or buprenorphine versus methadone prescriptions, Vermont tends to be, tends to favor buprenorphine and provide that more regularly than methadone. And I've heard anecdotally that that stems back to some policies when Howard Dean was our governor. But that just is sort of how our treatment centers tend to be set up. And that's actually written into Act 176 that buprenorphine should be the frontline treatment and offered first to folks who are initiating. And then the other medications should be considered, quote, as medically necessary. I don't know of any specific programs to try to promote use of methadone more in our state, but I definitely think that's something worth exploring.
Well, one of your
Yeah, I think
problems
that mobile. Go ahead, Jody.
being
Sorry.
so rural, it's hard to have method. You know, you need a concentrated group of people to have a methadone program. So you're all spread out all over the place. It's hard to connect people to care afterwards. And with requirement for daily dosing, if you live an hour or two away, you just can't do it.
Yeah. I just saw a comment pop up about sustained release buprenorphine, and I agree. When that becomes available, I think will be very helpful as well.
So Michelle Diorce had a question. Michelle, if you want to ask a question, that'd be great.
Yeah, sure. So in the beginning of your presentation, you had a graph about opioid fatal overdoses. And I was just curious, the line about prescription overdose deaths, was that involving other substances? Can you tell the difference whether it was prescription only or polysubstance?
So this was particular opioid related fatality in my, let me just share my screen again. Is this the graph you were talking about here?
Yes.
So these are, so the green line here, and this is in the community, so this is not limited to people who are recently released from incarceration. It is available on the Vermont Department of Health website. The green line here is prescription opioids. Dark blue is heroin, and then the lighter blue here is opioids involving fentanyl. So some opioid that included fentanyl in it. Does that answer your question?
I think so. I was wondering if the RX opioid, did it involve other substances? Can you tell in the death information whether it was prescription only or if it involved other substances?
I see what you're saying. I'm not sure about this particular graph. When it comes to the data I presented on overdose among people who were recently released from incarceration, so that was in the results section of my presentation, those were fatal and non-fatal overdoses that involved opioids, but could have and often did involve other substances as well.
Gotcha. Thank you.
Liz Evans has a question, or a couple questions actually.
Hi, Eli. Such
Liz.
amazing work. Yeah, and I love how you presented it. It's so clear. So thank you for taking the time to make the beautiful graphs. I think it makes it easy to tell the story, which is great. I had a question about the people on Medicaid. So in Vermont, when they're incarcerated, are they disenrolled from Medicaid or do they stay on it? And if they are disenrolled, how might that affect their ability to receive MOUD in the community, like after reentry? Is this an issue in Vermont or not so much?
That's a really good point. And they are disenrolled when they're incarcerated. And then there's a program in place to get them re-enrolled as they're being released into the community, or preferably before that release date. And so it's unclear from the data we have, these 20% or so that do not have Medicaid in the community, if these are folks who slipped through the cracks and are without insurance, or whether they have private insurance. But that's important. And I think the process of having to re-enroll someone inevitably could lead to folks slipping through the cracks, which would then be a substantial barrier to getting the medication or any treatment that they need in the community. So yeah, I think that's a very good point.
Yeah, it seems like a great potential topic for your qualitative work. Like your quantitative work could inform so much of the qualitative work. So it's exciting. You have that on deck after the new year. I guess my other big question, I had several questions, but my other question was just, you are preparing this for the legislature in January, which you've moved so rapidly. You have such access to this amazing data, which kudos to Vermont for making that possible. But I was wondering if you can anticipate any sort of the implications for policy or practice, given the findings so far.
You know, there were a couple of questions. So this is just being circulated around the DOC right now. And a couple of questions that came up. One is this decline in SUD counseling that is correlated with Act 176, or so, you know, we saw when MOUD became available in correctional facilities, MOUD in the community after release increased, and SUD counseling in the community decreased. And so there's a concern that that will be a question as to whether or not counseling should be encouraged or mandated for folks who are receiving MOUD in the community. And you know, I think it'll be important to reiterate some of this prior research where you know, we don't see substantial improvement in opioid use disorder outcomes when counseling is added to MOUD. And in fact, we don't want that to be a barrier to people engaging in MOUD. So I think that'll be an important point to touch on. And then other than that, you know, we'll see what the legislature has to talk about.
Yeah, it'll be interesting to see what they gravitate towards. And inevitably, it's also Vermont is so far ahead of what other states are doing. So this other discussion in other spheres of how can this maybe be looked at in other states elsewhere and replicated or adapted for those other settings. Yeah, great.
You know, I will say one other thing that just came to mind. Oh, sorry, Gil. One other thing that just came to mind, I think there will be a question about whether MOUD is being over-prescribed. And so one of the nice things that we have is OUD diagnosis data from Medicaid claims for people who are incarcerated. So these diagnoses happen prior to incarceration. And so we can talk about, you know, in our state, what proportion has a history or current or has an opioid use disorder within 3 years prior to their incarceration, and how does that align to the proportion that are actually receiving MOUD once they're incarcerated? I didn't present those data today, but they are actually surprisingly closely aligned, which I think is a good sign for the Department of Corrections.
Yeah, great, thank you. Looking forward to the next steps.
Thanks, Liz.
So there's
Tracy,
another,
go ahead.
there's another question in the chat box from Jen Lyon, and she's no longer with us, but several communities in Maine are providing overdose harm reduction bags. They include fentanyl test strips, Narcan, and resource guides. Our center, UVM Center on Rural Addiction, is providing the fentanyl test strips. Is DOC providing these?
Could you repeat the first part of that question? I cut out for a second, couldn't hear that.
Yeah, so it's just several communities in Maine are providing overdose harm reduction bags, fentanyl test strips, Narcan, and resource guides. Our center, UVM Center on Rural Addiction, is providing the fentanyl test strips. Is DOC providing these?
Yes, so Narcan is being provided. I don't know about fentanyl. Narcan is being provided as needed. I don't know about fentanyl test strips, but I can check on that.
And she just follows up with sustained release buprenorphine would be super helpful as well. And Dr. Green has a question, another question.
Sorry, but wrote in the chat, I wasn't sure if it was legible there, but I was wondering if for the 30 days post-release data, which were amazing, whether there are any differences or a sense of whether initiators or maintainers had a different pattern, or were they similar in their uptake?
Yes.
It looks like about
And-
40%. Yeah.
Yeah, and I believe, so we did look into this, and I believe that was in response to a suggestion you made the last time.
Oh.
Thank you for that. And there is a significant difference. So when collapse across time and within each time period, I didn't get a chance to present these today, but initiators were less likely to continue their medication upon release from incarceration, which then continuers, which tells a story that makes sense, being those who have established providers in the community prior to incarceration are more likely to continue in the community after incarceration than those who initiate. And the other piece that we looked at as we were, collapsing across time and looking at some of these variables was if males versus females different, and women were also less likely to follow up in the community within 30 days after release from incarceration. So 2 interesting points to follow up on there.
Yeah. Yeah. Great.
So that's sort of consistent with you're finding about counseling. The people who are incarcerated tend to have more advanced disease. They've taken greater risks, and they have they're more desperate, and they have more severe addiction. And so you think about counseling obviously is critical, important part of treatment, but if you've heard all the messages and you've been through the counseling and you kind of got it intellectually, but it's not really working, it's not clear that adding more counseling on top of that, after you had several years of counseling, more counseling may not buy you that much more. So the fact that in this population who's incarcerated, the counseling is dropping off doesn't seem to bother me so much as the medications. And there's some great stuff. I mean, Robert Schwartz did this wait list study where he took people waiting to get on methadone and just gave them methadone, no counseling, compared to the people that got in and got the counseling, mandated counseling, and really showed no difference. And I think it's similar population there. People trying to get into methadone for a long time are more advanced disease and have probably had all the counseling. I still think counseling is important, and people maybe the 5th time, 10th time round, they might actually hear it. It might make more sense. But I think mandating it and getting concerned that they're not getting it if they are actually taking the medications is more important. So, and then the women being sort of tougher than the men. I mean, we see that in women who are incarcerated at just about every level. Their needs are so much more. Their traumas are so much more. Their addiction is worse. And that's sort of a historic sort of reluctance to incarcerate women more than men. I mean, that's unfortunately fading, but anyhow, the women that are incarcerated have even more severe addiction than men, is my sense of it. But I think Tracy's right about thinking about people who are come into the system and haven't had the option of getting onto treatment. I mean, I think that's taking a generally not very helpful from a health or public health system, namely our criminal justice mass incarceration system, and turning it in a way that would be helpful, namely getting people connected to treatment. So I'm kind of thinking about, and obviously it's doing something with the overdose deaths and overdoses immediately post-release, which is great, but how many of those people can get on and stay on? And I'm wondering, since you're a unified system, whether that's for both prison and jail. In other words, somebody comes in and they're just there for 3 days for they're jailed for something, but you actually can get them started on treatment and then connect them to treatment on the outside. Boy, that could be a really life-changing and very beneficial event for everybody. But if you're, if the Department of Corrections is sort of dragging its feet, and it's not only that, it's, when somebody comes into the jail, they need to be evaluated, they need to be processed, and it's hard to know what's going on. And it's a scramble to get them any kind of health care, either evaluation or treatment. So can be, to get them started on treatment, get to understand, evaluated, that they need the treatment, and then connect them to treatment on the outside. It's really a tall order, but at the same time, potentially big payoff.
Yeah. Yeah, no, I think your point about, looking at jail versus prison in this unified system is really important. We have not looked at that as a specific variable. We did collapse across time, and then also within each period, look at length of incarceration, which you think would correlate, with jail.
Yeah.
And I was surprised to see that there were consistently in each time period no effect for length of incarceration as a predictor of follow-up within 30 days. I would like to see, I would like to plot that, even though there was no significant effect, start to look for a correlation. But I think that's a very important point.
We looked at that in some of our early studies before we had access with methadone, and the length of incarceration and the sentencing charge, and all these variables had really nothing. It was the most important predictor of whether they made it to treatment was that they got a dose the day before they left. If they had a dose, then they were much more likely to make it than anything else.
I wonder if we could get that kind of granular data in the Vermont Department of Corrections. I'll have to follow up on that to see.
That was methadone, but it's probably similar. The thing, 40% is kind of probably, I'm guessing, what we're seeing in Rhode Island in terms of, particularly in terms of newly initiated onto medications. And, that to me is the sort of next, there's things to follow up with that, to improve your system. And I'm really excited about the qualitative data to see what people are saying. And you probably want to, you want to get a sense of how available it is, and maybe get some people that aren't offered it that, find out why they weren't offered it.
Mm-hmm.
But that's sort of fine tuning the system, and kicking people off of it that's crazy. For diversion, it's, people divert for a lot of different reasons, and it doesn't mean they don't need it. They could be coerced into giving it, or they could, have a dose that's maybe too high, but and that's the setting with buprenorphine diversion, which is really where we see it, where we've moved, the Department of Corrections has moved toward injectable long-acting, and we've got about 40 patients that have been on treatment so far, and that's going well. So it's not that they don't, that it's obviously more difficult to divert something that's been injected into you.
This issue that you brought up about the 40%, any way we sliced it, it was less than half of people who had an MOUD prescription followed up in the community to release. And that to me is sort of the glaring big system.
Right.
How do we improve continuation of care?
And
how do
that
we
is
deal with the ongoing pandemic?
Yeah, absolutely. That is the critical issue in my mind, is like what's happening to half those people that are dropping off. It could be logistical, it could be attitude, it could be their disease process, it could be it could be all kinds of things. But if we can drill down on that, figure out what's going on, and what happens to these people longitudinally. People getting started on treatment in the community, not through corrections, have a high dropout rate as well, but I don't think it's quite as high as that. So
well, I'll just finish that thought with our hope here, especially being VCBH with Steve Higgins right upstairs, is to work on some sort of contingency management to increase adherence and sort of target that critical period, the month after release from incarceration.
Great idea.
Well,
Okay, Gail, I think we're at time.
we are at time. No more questions. Just want to thank everybody for coming to this talk and wish everybody a happy and safe holiday season.
Thanks so much. Really
Great.
appreciate the opportunity to talk today.
Thank you.